true ischemic chest pain. So what do you do? Suppose you are to be facing the patient first and you have a small office of your own. What will you do for this patient?
So immediately in such cases, we should give patient antiplatelet and statin loading. That is aspirin 300 mg, clopidogrel 300 mg, atorvastatin 80 mg. And if he has rest angina in front of you, then give sublingual sorbitrate if blood pressure is more than 110 mmHg. If it is less, then preferably avoid sorbitrate. But these three medications, that is aspirin, clopidogrel and atorvastatin, should be given immediately. And next step is we should assess the patient in the form of cardiac enzyme to risk stratify that patient, whether it is just unstable angina or whether it is unstable.
How many of you are doing troponins in your office? Most of you are not doing that, or most of you are doing? It's a very simple test, just finger prick, and you put a tape on this thing, and it gives you positivity. So positive troponin abnormal ECG clearly tells you that you are dealing with acute coronary pain. Also, troponin tells you whether you are dealing with a bigger problem or a smaller problem. So a small rise in troponin, you're probably dealing with a smaller muscle injury, while a high steep rise indicates a bigger myocardial angiopathy. So small rise, big rise, and mortality is clearly higher in initial. So whenever you have a strongly positive troponin, you are going to clearly worry and do things in a quicker way. So this patient undergoes any other test, or you go straight for angio? You admit the patient?
Yeah, definitely. After antiplatelet loading, and if patient is troponin positive, then he should be immediately admitted. Depending on his blood pressure and blood sugar level, we should start him on NTG infusion.
So in first case, we saw ECG was okay. In the second case, you may be having some ECG abnormality. At the moment, we are not talking of ST elevation MR, which you already heard in the morning. So if you are dealing with this kind of slightly abnormal ECG, typical chest pain, multiple risk factors, and a troponin positive. So this is a clear case that you are dealing with a coronary, acute coronary event. A troponin is positive. So you are dealing with not either unstable angina, but since troponin positive, you are going to call this non-ST elevation MR. All right, so troponin positive is differentiating factor between unstable angina and non-ST elevation. So as Ranjan says that we should admit this patient. Now, how urgent, that's an issue, because most of the time when you tell the patients that this is a coronary event, let's admit you, the reaction is no, it's not, disease is not for never for me. So they would probably try and find out some ways, can't I stay at home tonight and things like that. But if you have an ST elevation, there is no choice. This has to be acute response from doctors. It could be in form of giving them lytic, give any of the lytics, or you can do a direct angio and angioplasty. So we are not talking of ST elevation, we are talking of an ACS, acute coronary syndrome, troponin positive. ST is not elevated, and in these cases, you may have dynamic ECG changes, echo showing some wall motion abnormality, there may be some LV dysfunction. So these are the cases where you definitely admit them and put them on low molecular weight heparin. So in addition to antiplatelet, high dose statin, you put them on low molecular weight heparin. And then angio is required here as well as here. Is there any sense in terms of timing?
Usually in cases of staining, we go for urgent invasive management, that is immediate immediately patient should be angio to be done and see for anatomy. For NSTEMI, we go for early angio, that is angiography after first 24 hours. After 24 hours, we go for angiography, that is invasive therapy. Urgent invasive is not required in NSTEMI.
All right, so that is this thing, and this is the last case which we wanted to discuss. This is again age group where you can expect coronary disease. The patient is again diabetics, and he had anterior wall MI, delayed presentation. Now, when you ask a patient when was the pain, he would probably say 1 hour back, 2 hours back. So there is a general denial that there is a pain, and whatever pain, thoda hota hai, that kind of story. But you have to get into details and really ask him, well, did he go for work the previous day? If he said no, you have to ask him why he didn't go many times. They have some kind of discomfort, and then they don't go for work, take it easy, and so on. So this onset of MI is very important, because if you're dealing with a case who is coming to us after 24 hours, the reaction is going to be quite different. In this particular case, patient has cardiac shock, so decision to angioplasty LAD is very important. So these kind of cases where patient is cold, patient has got an ST elevation, you must do an emergency angio and an emergency angioplasty. This patient, despite everything done quickly, has a low ejection fraction. Now this also you must tell the patient that though we are doing an emergency angioplasty, if patient has presented late, some myocardial damage has already taken place. So we don't expect this patient to have a normal ventricle. If patient has come really early, say within first hour, and if you open the artery, you might even get completely normal ventricle. But most of the time, especially with an anterior MI presenting late, you'll always have some degree of loss of LV function. So this was the hyperacute kind of T wave. So this patient had an ECG done in the early phase, did not react. And this is how things can go wrong. This is actually not the same case, but as ECG was being taken, patient has gone into ventricular fibrillation. So this patient had to be shocked multiple times. The ECG finally indicated an anterior MI, some VT episode in the early phase before finally the patient settled, but yet has a persistent ST elevation. So ST elevation has to be treated quite differently. You want to explain the progression of MI?
So as we have discussed, the importance of time in ST elevation. As the time progresses, the damage goes on increasing. As we know that coronaries run epicardially, so the subendocardial portion is the most distal to the epicardial coronary artery. So damage starts from subendocardial part of the myocardium, and it goes on progressing. So earliest intervention done gives us maximum benefit. So we call it as time is muscle. So as time passes, there is more and more muscle is damaged, and chances of recovery, that is improvement in ejection fraction, goes on decreasing, and that is the most important thing to be preserved in cases of ST elevation or any acute coronary syndrome. In long term prognosis of the patient, ejection fraction is the most important thing. If we could not preserve that ejection fraction, that is we could not preserve the muscle, then permanent damage happens, and mostly after 6 to 8 hours there is permanent damage, and chances that there will be full recovery is very less.
Actually, this is where I feel the importance of a family physician is extremely important. Patient sees me for the first time. When I tell him that you have an infarct and we need to do an angiogram, most of the time his reaction, they know you are telling us something funny. So here, if the the family physician is there telling the patient that yes, this is all true, this is the way we should go, I think patient would really benefit, because you are trying to do everything in first 1 hour. See the benefit coming in first 1 hour is extremely good, and then whatever you do, the benefit is never going to be as strong as first 1 hour. So the initial hour is extremely important. Now this is very true whenever you have a ST elevation, the timing. When you do not have an ST elevation, then you have time. You can start all the low molecular weight, heparin, etc., and do the angiogram next morning. Now we have two kinds of intensive care units in majority of the areas. Those who are non-PCI centers, that means they do not have a cath lab, or even if they have cath lab, they are not geared for doing 24/7 angioplasty. While we have cath labs which are potentially working 24/7. So if a patient goes with an ST elevation to this kind of center, this is the way you should push the patient, that if you see an ST elevation, tell them to go to a center which can do an emergency angioplasty. Because even if he goes here, you would probably not get the angio or angioplasty. They would get thrombolytic treatment, and then the patient will have to be shifted to the PCI center. Now you want to talk a little bit about the first medical contact. FMC is the first medical contact. Most of the time when we talk to the patient, when did the pain start? It's the first doctor he went to, and from there you start counting the time. But truly, you have to ask him, when did the pain start? Whether was he all right the previous night when he had dinner? Did he go for work the previous day, and so on. So a little bit about first medical contact.
It is observed that in India, first medical contact is the time for patient to contact a medical person. That is the most important and most crucial part of the delay happening, because patient most of the time don't identify the symptoms that it is a cardiac problem, or even if they identify, there is a denial. So
this is the patient delay that he's talking.
Patient delay. So once they go to physician, family physician, general practitioner, from there treatment starts. So we usually start with antiplatelet, statin, or sorbitol, depending on his blood pressure. There onwards, the delay should be minimum possible. If patient residing at far away situation where medical facilities are not possible, then there is a concept called as pharmaco-invasive management, in which case if PCI center is far away, then we can thrombolize the patient. We have a bolus thrombolytic available in the form of reteplase or tenecteplase. Bolus thrombolytics can be given, and that patient can be shifted to PCI center. So, and PCI or invasive management can be done after 3 and within 24 hours.
So the delay can be on the patient side, delay could be on the side of the medical team which is treating the coronary case, and the delay could be in the cath lab and around. So we have to sort of cut down the delay at every stage, make our patient understand that he must go for treatment. We are just going to touch a little bit on the antiplatelet therapy. So most of the time these days, acute MI or HCIS, patient will go for an angio, would probably end up with angioplasty. So when patient comes to the family physician, patient will be on statin, patient will be on beta blocker, and patient will be generally on ramipril ACE inhibitor. So these three are a must. In addition, the antiplatelet agents are again very important. So we have aspirin, and we have aspirin clopidogrel, which was long for many years And in last about 4 or 5 years, we have Prasugrel and we have Trachegrel. So these two are sort of newer antiplatelets. Whenever there is an acute case, an ACS, ST elevation or non-ST elevation, these two perform better. So these two we use on regular basis in an acute case, while if you are doing a standard angioplasty, many times you use Courtyard. It is very important to emphasize on the patient's mind that one stent, the patient must go home with one of these, aspirin for everybody and one of the antiplatelet agents for others. You want to talk one word about how you can stop if the procedure is required? Sorry.
Next slide.
Next slide.
So if a patient is on a DAPT therapy and he has to undergo any non-cardiac intervention, then timing is very important because we cannot stop antiplatelet for first at least 5 to 6 months. So in cases of patient receiving drug-eluting stent, antiplatelet cannot be stopped for elective surgery for first 6 months. After
so you ask a question whether the elective surgery, whatever, can be delayed to about 6 months. If the answer is yes, try and delay it for 6 months so that we don't run into any problems related to antiplatelet therapy. After 6 months.
After 6 months, we can stop antiplatelet for 3 to 5 days pre-operatively, and depending on the type of surgery, we can restart it after 24 to 48 hours. That can be done.
So keep the off period to minimum and restart at the earliest after the surgery. This is our team, we all work together. And so about today's invitation, I think I'm really obliged to the Marriott group, especially Rajesh, JS, and my very close friends. We work at AIMS, me and Rajda. So it was on behalf of AIMS too that we have been talking to all of you. And this is some of our team members whom you may have already interacted with. Thank you indeed.
Thank you, sir. What a wonderful session, and it is always a pleasure to have you. I would request Dr. Pramod Mukherjee, sir, to please felicitate Dr. Hiremath, sir. A big round of applause for Dr. Hiremath, sir. I would request Dr. Inamdar, sir, to please felicitate Dr. Pramod Mukherjee and Dr. Devre. Dr. Inamdar, sir, please. It's really great to have such a senior physician. Thank you, sir.
Senior also means older.
Experienced, sir.
You got a question?
Glad to receive at the hands of Dr. Hiremath.
Thank you, sir.